Hello, welcome to this YouTube channel. Today we're going to discuss on abruptio placenta, which is an important topic in obstetrics. So we're going to discuss on definition, risk factors, pathogenesis, clinical features, diagnosis, management, and complications. So please subscribe to my YouTube channel. This is a new YouTube channel, so I need your help. Okay, let's get started. Definition. Okay, definition of abruptio placenta is very simple. It is one form of APH where the bleeding occurs due to the premature separation of normally situated placenta. You know, placenta is normally attached to the uterine wall around the fundus. So if this normally situated placenta is detached or separated from the uterine wall before third stage of labor, that is called abruptio placenta. Okay, when it comes to its incidence, it's around 1 in 200 deliveries. That's not very common, but still is important. Okay, types, we have 3 types: revealed, concealed, and mixed, depending on how the bleeding occur. Okay, in revealed one, blood comes out of the cervical canal to be visible externally. So it is visible because the bleeding is visible, which comes from the area of separation of placenta from the uterine wall. As you see from this picture, the bleeding is here. So the bleeding is coming out of the vagina, out of the cervix, which is visible into the vagina. So this one is quite common. So this one is one type. Okay, the other is concealed one, where there is no bleeding visible outside the vagina. The bleeding is collected in between placenta and the decidua. So you can't see any bleeding outside. Look, this area is a collection of blood, which is collected between the decidua and the placenta. So in this type, there's no outside visible bleeding. So this is very rare, and it is very dangerous because the blood is there collected inside the uterus. So we don't know what the condition is. So this is very dangerous. The other is mixed, where some part of the blood collects inside and a part is expelled out. This is the most common one, and but we can't really estimate how much amount of blood is collected inside. So this is the common one. What you have to remember is the bleeding is almost always maternal. There is no fetal bleeding in abruptio placenta because the bleeding is from the maternal side, not the fetal side. So almost always the bleeding is from the maternal side. Okay, when we come to the risk factor, we don't know the exact cause of abruptio placenta, but there are, the etiology is idiopathic. That means we don't understand what is the cause. The real cause is not understood yet. Okay, when we come to the risk factors, the first risk factor is high birth order. That means gravida 5 or more mother is at risk of developing this abruptio placenta because as the age increases plus the amount of birth or gravidity increases, the uterus is not good as compared to those who have lower gravidity and parity. So the risk is increased. The other is hypertension. Hypertension is the greatest risk factor of abruptio placenta. We have different types of hypertension, like chronic hypertension, preeclampsia, eclampsia, gestational hypertension, and HELP syndrome, where the complication is very severe in case of preeclampsia and eclampsia. Okay, so this one is hypertension is the single most common risk factor. So in hypertension, there is a spasm of blood vessels. You can see this is normal blood vessel that supplies the placenta. But in case of hypertension, look here, there is constriction, there is twisting, and the anatomy is not very good. So that means there is a decrement in a blood flow that goes to the placenta. So if there is a blood flow and if there is low blood flow and the spasm of the vessels, there is anoxic endothelial damage because of lack of oxygen. So if there is lack of oxygen, there will be a rupture of vessels. So rupture means if there is rupture, there is retroplacental hematoma that leads to abruptio placenta. So this one is the very, very important risk factor. The other is previous history. A woman or a mother with previous history of abruptio placenta is at risk of getting abruption. The recurrence is 7% in mild case of previous abruption, and if it was severe abruption, that will lead us to 12% of abruption again. And if too severe pure abruption, around 15, that means half of the women will develop abruptio placenta again. The management is difficult because of sudden rupture. We don't know the exact time that the abruption will occur, so it is unpredictable. So previous history is one risk factor. The other is chorioamnionitis. That means an infection of amniotic fluid, so that increases by threefold this sudden decompression. This happened in polyhydramnios, multiple pregnancy, premature, preterm Rome, and also that means rupture of membrane, preterm rupture of membrane, multiple gestation. In these cases, the uterus was distended very severely, or distended in a great manner. After these things, usually in polyhydramnios and multiple pregnancy, when there is sudden decompression or leakage of something out of the uterus, the surface area of the uterus is decreased. At that time, there is a shearing and detachment of placenta. Okay, the other is trauma. It is obvious that trauma will include external cephalic version, where the doctor will try to change the breech presentation into a cephalic presentation. If it is done under anesthesia, where the woman do not sense the pain, so that increases the risk of abruption. Road traffic accident, that's the vehicle, and a needle puncture at amniocentesis, where we take amniotic fluid sample by needle, so that increases the risk of abruption. Smoking also increases by twofold this, and increases smoking also increases hypertension, which increases risk of abruption. The other is uterine anomalies. If the uterus has some abnormality like septate uterus or fibroid, that increases also abruption. Aging, as the age increases, the tissue of the uterus and the placenta are fragile, and they're not as good as those other age group, so it increases. Poor socioeconomic status. Like if there is poor socioeconomic status, there will be a malnutrition, trauma, poor follow-up. These things increases the risk of abruptio placenta. So these are some risk factors. Okay, pathogenesis. So the pathogenesis depends on the etiological factor, but generally the pathway is similar. So hemorrhage into decidual bacillus first. Due to the risk factor, there will be some causes. So there is hemorrhage into decidual bacillus, then degeneration and necrosis of decidual bacillus. So if there is necrosis, then there is damaging of adjacent placenta. The adjacent placenta that is attached to the decidual bacillus is damaged. So that leads to a rupture of basal plate. So rupture of basal plate means there is a bleeding. So the bleeding may cause retroplacental hematoma. So this blood, the collected blood between the placenta and the decidua, sometimes the blood may go outside totally. There may be a leakage of that bleeding into the canal, into the vagina, then it will be visible outside. And sometimes, in very rare cases, there will be a concealed collection of blood between the placenta and the decidua. So that's the very dangerous, as we discussed earlier. In most cases, there will be mixed. Some part will collect it there, and some part will be visible outside the vagina. So in this case, some blood is visible outside, and some blood is collected there. Okay, in these two, in the concealed and mixed one, the blood will extravasate into the myometrial part, the muscular part of the uterus, and that may cause a cavalier uterus, sometimes called uteroplacental apoplexy. So that's very dangerous, and the uterus may look like this, or we find this during laparotomy. So this is the very rare complication, but it is very severe. Okay, changes in organ. In liver, there will be fibrin nodes. In kidneys, cortical necrosis and proteinuria. There will be blood coagulopathy. CNS, there will be altered mental status. Okay, clinical features. So the clinical features depends on degree of separation, speed of separation, amount of concealed bleeding, and temporal nature. That means whether it is acute or chronic. So the features, there will be vaginal bleeding, abdominal pain, uterine contraction, and abnormal fetal heart rate pattern, or generally the condition of the fetus will be abnormal. So Others like pallor due to the bleeding, feature of DIC, there will be a bleeding from other part of the body. There will be preterm labor due to early contraction, and there will be premature rupture of membrane. If it is chronic, there will be intrauterine growth restriction. So these are some features. When you see vaginal bleeding, the vaginal bleeding is usually dark and continuous, and the blood, sometimes there will be a blood-stained discharge through the vagina. Abdominal pain, or generally the abdomen will be big for a period of gestation because some blood will be collected inside the uterus between the placenta and the decidua that will lead us to enlargement of the abdomen. So the abdomen will be large for gestation when we compare it to a period of menstruation. So that's one finding. But sometimes there will be a proportional to period of gestation. Difficult to palpate fetal parts because there will be a collection of blood. The abdomen is very tense, it's strong, so we can't palpate the part of the fetus easily. And plus, during examination, the abdomen will be tense or it's tender and painful. Okay, uterine contraction, the uterus will become tender, tachysystole, there's no relaxation period between contractions, so it will be rigid and globular. So that's the contraction become very tense and rigid. Okay, diagnosis. When we come to diagnosis, primarily the diagnosis of abruptio placenta is through clinical. So clinically, you can identify the risk factors through history and also vaginal bleeding. The vaginal bleeding will suggest us something like if there is a dark and continuous and a blood-stained discharge, that's called, usually if it is dark bleeding, that suggests us abruptio placenta. Abdominal pain, or the abdomen will be big for gestational age, difficult to palpate, and the abdomen is tender, painful, so that suggests some feature of abruptio placenta. Uterine contraction, so the uterus become tender, tachysystole, rigid, and globular. So that suggests us abruptio placenta. Fetal heart rate will be abnormal, feature of shock. One thing you have to understand or you have to remember is never do vaginal examination unless placenta previa is ruled out. Because if you do a vaginal examination in placenta previa, that's very dangerous. That will augment bleeding, and that leads to very severe complications. Okay, lab investigation, there will be low hemoglobin level and prolonged clotting time because there's high consumption of clotting factors, usually in concealed bleeding, and a low platelet count, low fibrinogen level, that's usually less than 150 milligram per deciliter, and there will be a proteinuria and on urine dipstick. So these are some lab findings. Ultrasound will help us something like it show us subchorionic clots, as you see from the picture. Subchorionic clot is, a clot that is found between a placenta and fetal membrane. So that's the collection of blood between placenta and fetal membrane. A retroplacental clot, that is a collection between the decidua and placenta. And the other is preplacental, that's a collection of blood between placenta and amniotic cavities. We can see these things through ultrasound. And also ultrasound is very helpful to rule out placenta previa because there are some common feature of placenta previa and abruptio placenta, but not. Negative finding of ultrasound does not totally rule out the presence of abruptio placenta. So sometimes it is difficult. And also if the finding of ultrasound is equivocal or inconclusive, MRI is very sensitive for this case. Okay, and the amount of shock is not proportional to the amount of bleeding. So you have to know the amount of shock is not the same as the amount of bleeding, because the bleeding may be collected inside that is not visible. So the amount of the shock is not proportional to the amount of bleeding. Okay, differential diagnosis, so rupture of uterus, rectus sheath hematoma, appendicular or intestinal perforation, twisted ovarian tumor, volvulus, acute hydramnios, tonic uterine contraction are some differential diagnosis. So read a lot about these things to differentiate from abruptio placenta. Okay, the management part. So the management, before management, prevention is very important in abruptio placenta. So early detection and treatment of pregnancy-induced hypertension is very important because hypertension is the most common risk factor of abruption. So correcting these things is very So correcting pregnancy-induced hypertension and treating is very important. And correct anemia, caution on amniocentesis should be ultrasound guided, and also avoidance of trauma. Avoid sudden decompression of uterus, because this increases the detachment of placenta. Routine folic acid administration also very important. So generally treatment depends on severity, gestational age, fetal maternal condition. So these three things, depending on these three things, we can manage it. As a general measure, we have to quick assessment, IV fluid laboratory investigation like hemoglobin or hematocrit, or a cross-matching, very important. And blood transfusion if necessary to correct DIC if DIC has occurred. And fetal monitoring is very important. So the treatment, have two treatment options. These are expectant or immediate. In expectant, usually this is not done. Usually it's rarely done. So this is done if remote from term, usually if gestational age is less than 34 weeks. So in this case, both maternal and neonatal conditions should be very good. And this is usually done for administration of corticosteroid that used to fetal lung maturity. Delivery is needed immediately. It could be a vaginal delivery or cesarean section. The vaginal delivery is preferred in abruptio placenta. And to induce labor, we have to do ARM, that's artificial rupture of membrane, to augment. And if labor is not strong enough, we can use oxytocin. And cesarean section is reserved for severe abrasion with live fetus and unfavorable cervix and failed induction and other obstetrical indications, like if there is malpresentation or if there is a contracted pelvis, that is indication of cesarean section. Advantages of ARM, or artificial rupture of membrane: it augments contraction and also labor progress, and it arrests bleeding, because when amniotic fluid is escaped from the uterus will collide each other, so that reduces bleeding, reduce entry of thromboplastin to the maternal circulation, and also it reduces a risk of DIC. So ARM is very important to induce the labor and it reduce bleeding. Okay, complications. So these are some complications. There will be hemorrhage, shock, coagulation disorders, and postpartum hemorrhage, puerperal sepsis, Sheehan syndrome, and maternal death and fetal death. Shock is not appropriate with the amount of bleeding. We have already discussed that. And coagulation disorders is due to high consumption of platelet factors, and postpartum hemorrhage is due to atonic uterus and increase in serum FDP. And also puerperal sepsis is due to the management, and also the immunity of the mother will be dropped. And Sheehan syndrome, ischemic pituitary necrosis. Sheehan syndrome is a syndrome in which pituitary is necrotized due to bleeding. This leads to a failure of lactation. Also, maternal death is usually due to hemorrhage, shock, coagulation failure, and renal failure. Fetal death, the two most common factors of fetal death are prematurity and anoxia. So prematurity is the most common cause of fetal death in abruptio placenta. So as a quick recap, so abruptio placenta means a premature separation of normally situated placenta. Common risk factors are pregnancy-induced hypertension, previous history, and high parity, trauma, smoking. And the clinical features may include vaginal bleeding, abdominal pain, that's tense, rigid, and tachycecal uterus, and fetal condition abnormalities may be detected. And the diagnosis is mainly clinical. Delivery is definitive treatment. Vaginal delivery is preferred method than cesarean section. So this is it. Thank you for watching, and please subscribe to my YouTube channel. I will meet you next time. Thank you.